This video will review the bone and muscle of the shoulder complex, so we'll talk about the scapulothoracic joint and the glenohumeral joint, as well as the connection with the clavicle. We will focus on the bones and the bony prominences, as well as the muscles, their origin, insertion, innervation, and action. When we consider the scapula, the first thing that we want to do is identify if we're looking at the anterior or the posterior aspect of the scapula. So if we think of the scapula as it would sit on the body, the anterior side would articulate with the ribs. So this flat, open surface is the anterior aspect, and the posterior aspect has the spine that runs down the middle. So once we identify the anterior and posterior side, we also want to identify the medial and the lateral borders. So if we look at the glenohumeral, or the glenoid fossa, this is the articulation for the glenohumeral joint, where the glenoid fossa would articulate with the humerus. So if we think of the scapula as it would sit on the body, this is always towards the outside. Our shoulder sits on the outside of our body. So this is the lateral border, and then the border that does not have the glenoid fossa is the medial border. So again, if we look at it from the posterior side, the glenoid fossa would be right here. So we have the lateral border and the medial border. And then we also have the superior border on both of them. From there, we can also identify angles. So we have the superior angle on the top portion and the inferior angle on the bottom. So one more time, we have the lateral border, medial border, inferior angle, superior angle, medial border, lateral border, superior angle, inferior angle, anterior surface, posterior surface. Our glenoid fossa, again, always sits on the lateral edge, and this is the round portion where the shoulder, or essentially what we would call the shoulder joint, is created, the glenohumeral joint. This is where the scapula will articulate with the humerus. We also have two other prominences that are important to note. We have our coracoid process and our acromion process. Our coracoid process is towards the anterior aspect and kind of comes up over the front of the scapula. And then our acromion process is off the posterior side, and that will create the articulation or the AC joint. So again, here we have our acromion process on the posterior side, and if we look past that onto the anterior side, we have the coracoid process. On the posterior side, we have two main fossas. We have the supraspinatus fossa and the infraspinatus fossa. Again, we call the spine down the middle, the spine, and then above that, again, supraspinous fossa and infraspinous fossa. On the anterior side, the opening, we call the subscapular fossa. We have two main tubercles that we associate with the shoulder. We have the infraglenoid tubercle and the supraglenoid tubercle. We also have one small notch that we call the superior notch that sits just beside the coracoid process. Here on the posterior view, we can see that infraglenoid tubercle as well as the superior notch. Moving on to the clavicle. The most important thing when you're looking at the clavicle is making sure that you're appropriately identifying the acromial and the sternal ends. So the acromial end is the end that's more rounded. The articulation, when we look at the AC joint specifically, it's kind of almost a gliding articulation where the two surfaces are fairly flat and they just sit together flush. So again, that's the more rounded end. So this is what we call the acromial end. And then the flatter end is the sternal end. If we picture the SC joint, and we'll see that here in a minute, the clavicle and the sternum sit really flush together. This is one of our diarthrodial joints. So again, we don't have a lot of movement. They sit really close. So our flatter end is what we'll call our sternal end. We also want to be able to identify if we're looking at the anterior or the posterior surface. So when we look at this, again, when we identify the sternal end, the kind of rougher aspect of the sternal end is looking towards kind of the anterior side. So this would be on the other side would be our posterior side, and here we would have our anterior side. Versus on the other end, when we have a little bit rougher view of our acromial end, this again is going to be the posterior side, and the other side here would be the anterior side. So essentially we're looking at this one on the left, we're kind of looking at that from more of like an inferior view and kind of from the back, and then the one on the right would be a superior view and kind of from the front. Moving on to the humerus, here we have a few more prominences that are really important because this is where our muscles and our ligaments and things that we'll talk about in relation to movements of the shoulder joint typically attach. So the most important thing and where we want to start is the head of the humerus. So this round kind of prominence where we would articulate with our glenoid fossa is what we call the head of the humerus. Again, it's nice and round and it's nice and smooth. It will be covered in hyaline cartilage that we'll talk about in class. And then down at the bottom, we have the articulation that will create the elbow. So we're not going to spend a lot of time on that because we'll get into that with our next video on the elbow. So the two important prominences in the shoulder are the tubercles. So we have a greater tubercle and a lesser tubercle. So the greater tubercle is the larger prominence that sits more to the lateral aspect, and then the lesser tubercle is the smaller prominence. So when we're looking at these two humeri, the one on the left would be an anterior view, and the one on the right would be a posterior view. So the one on the left we'd be looking at like we were looking at somebody, and the one on the right would be as if we were looking at their back. So again, the greater tubercle is the one that's more to the lateral side or the outside, and then the lesser tubercle is a little bit more to the medial aspect, again, when we're looking from the front view. We can also see that greater tubercle from the posterior view. In between those two tubercles, we have an area that we call the intertubercle groove. And this is where our biceps tendon will run. So you'll also hear this called the bicipital groove, and either of those is completely appropriate. Down below our greater tubercle and kind of to the outside of that groove, we have an area that we call the crest of the greater tubercle. And again, that's kind of just the ridge that runs along the outside of that groove, either the intertubercular groove or the bicipital groove, depending which you're going to call it. And then on the medial side of that groove, we have the same thing, and we call that the crest of the lesser tubercle. Moving distally on the humerus, we have this one bump on the outside, and we call this the deltoid tuberosity, and obviously this is where our deltoid is going to insert. And then on the posterior view, just kind of distal to that deltoid tuberosity, we have the groove for the radial nerve. So as we get a little bit more into the innervations in class, we'll look at where specifically those nerves run in relation to the bone and what impact that can have on the muscle activation, especially in the upper extremity. When we put these three bones together, we get the complex that we call the shoulder girdle. So the shoulder girdle is made up of 4 different joints. We'll look at each of those joints, and again, it's important to remember when we're talking about the shoulder that we identify the joints appropriately because there are so many joints that live within this complex. So let's run through really quick all of those prominences and bumps that we found on all these bones just one more time. So again, we have that anterior surface of the scapula where it articulates with the ribs, called the subscapular fossa, posterior surface with the spine, supraspinous fossa, and infraspinous fossa. Here we have our lateral borders, medial border, superior border with our superior angles, and our inferior angle. The glenoid is articulating with the humeral head, again creating that glenohumeral joint. And again, we have on the top, we have that supraglenoid tubercle, and then we have the infraglenoid tubercle underneath. We have the superior notch, and then we see the clavicle crosses over just kind of in front of or over top of that notch, between the notch and the superior angle. We have our acromion process on the posterior side, and that articulates again with the clavicle, creating the acromioclavicular joint or the AC joint. And then we have the coracoid process off of the anterior side. We also have the sternal end of the clavicle where it would articulate with the sternum, and that creates our sternoclavicular joint. Again, that's one of our more synarthrotic joints. Diarthrotic, we'll talk about that a lot in class. It doesn't have a lot of mobility. Moving on to the humerus. We have the humeral head, again, which is where we articulate with the glenoid, creating the glenohumeral joint. We have our greater tubercle more laterally, and our lesser tubercle more medially. So the greater tubercle here from the posterior view again. Between those two, we have the intertubercular groove, or the bicipital groove, and coming down from each of the respective tubercles, we have the crest. So we have the greater tubercle crest and the lesser tubercle crest. We also have the deltoid tuberosity that we can't quite see on our anterior view, as well as the groove for the radial nerve. So it's important as we begin to consider the muscles and their innervation that we understand where these innervations are coming from in the body. So all of the nerves that innervate the shoulder complex are coming from essentially C5 to T1 nerve roots, but we also have a very small contribution from C4 and T2 that we also consider as well. So these nerves come out of the nerve roots, and then we enter what's called the brachial plexus. So the brachial plexus is split into several different divisions. So to start with, we have 5 roots, and again, these are the nerve roots that are coming out of the spinal cord. So we have C5, C6, C7, C8, and T1. From there, they begin to branch off and differentiate. So you can see almost instantly, as soon as they come out of the spinal cord, they begin to branch off. So C5 instantly begins to go to the dorsal scapular nerve, as well as has a branch that goes to the phrenic nerve, and then goes to the longus colli and scalene muscles. When we look at C6, it more just comes down our chain and is going to transition into other nerves, as well as C7 and C8. And then when we get down into T1 is where we see our first intercostal nerve. So after we go through those 5 roots, they branch and form 3 trunks. So we have a superior, a middle, and an inferior trunk. Again, this is after they have crossed this point where we branch into these 3 trunks. We're no longer considering them to be nerve roots. We just consider them trunks of the brachial plexus. So the superior trunk has one section that goes to the suprascapular nerve, as well as the subclavius muscle. Our middle and our inferior do not branch off. Here we can also see this C5, C6, C7 blend that we call the long thoracic nerve. So this is one of our nerves that's really important, and you'll talk about this in a lot of different places, but where we see this mostly is in people with scapular winging, having some long thoracic nerve palsy, and we'll talk about that a little bit more in class. So after our 3 trunks, then we go into 3 anterior divisions and 3 posterior divisions. So they're labeled with A's for anterior and P's for posterior. Again, it's just the separation of those 3 trunks into 6 more. It's also important to note here that this is where we see the first rib. So your first rib sits really high, and it's coming off of our first thoracic vertebrae, right below our C7. So this nerve, our nerves here in our brachial plexus, specifically the inferior trunk, runs right over top of and really in close relation to that first rib. So we'll talk about that as well in class, about how the musculature can impact the integrity essentially of the brachial plexus due to their close proximity to that first rib. After we go through our divisions, again, we have 3 anterior, 3 posterior, creating 6 divisions. They form back together and reorganize into 3 cords. We have a lateral, posterior, and a medial cord. Our lateral cord goes into the lateral pectoral nerve, and then we have this blend between the lateral and the medial, and then kind of branching off onto the medial into the medial pectoral nerve. Also off of medial, we have our medial cutaneous nerve of the arm and of the forearm. And then looking at the posterior, we have our upper subscapular nerve, our thoracodorsal middle subscapular nerve, and then our lower subscapular nerve. After we go through those 3 cords, we split into our final terminal branches, and where we see the musculocutaneous nerve, the axillary nerve, radial nerve, median nerve, and ulnar nerve. So these are the 5 main nerves when we're talking about the innervation of muscles that we'll be talking about. Obviously, our pectoral nerves will be important. We can obviously guess that they're going to innervate the pecs. And then we also see some of our nerves that are going to innervate the rotator cuff, and again, that long thoracic nerve. So we just want to make sure that we have a good idea where they're coming from. We'll walk through this plexus again in class, making sure that we really understand where we're going and what these divisions are. Moving on to the muscles of the shoulder, we're going to begin with the deltoid. The deltoid is one of the most prominent, important, essentially, muscles of the shoulder, and it's responsible for a lot of the movements, or it contributes to a lot of movements that occur in the shoulder. So the deltoid is split into 3 divisions. We have an anterior division that we can see on the front here, and then we have a middle division here, and we have a posterior division. Again, we identify our divisions by which side of the body they're sitting on, so anterior, middle, or lateral and posterior. Again, we know this is the posterior side of the scapula because we identify the spine as well as the clavicle. So the deltoid originates on the lateral third of the clavicle, the acromion, and the spine of the scapula. So if we look at our three divisions, the posterior division originates on the spine of the scapula. Our middle division originates from the acromion in the spine of the scapula, and then our anterior division originates on the clavicle and the acromion. And then all three of them insert on that deltoid tubercle. This is one of our multi-pennate muscles, so we have a lot of origins up at the top with multiple tendons, and then they all converge into one tendon to insert onto the deltoid tuberosity on the humerus. The deltoid is innervated from the axillary nerve, coming from C5 and C6 nerve roots, and the deltoid is responsible for multiple motions of the glenohumeral joint. So all of the fibers contribute to abduction of the glenohumeral joint, and then the anterior fibers specifically are responsible for flexion, medial or internal rotation, and horizontal adduction of the glenohumeral joint. And the posterior fibers are responsible for extension, lateral or external rotation, and horizontal abduction of the glenohumeral joint. The trapezius is the second muscle that we split into different divisions. So we have the upper fibers, and these are the fibers that essentially sit on top of the scapula. We have the middle fibers, and then we have the lower fibers. So the trapezius originates on the external occipital protuberance, the medial portion of the superior nuchal line of the occiput, the ligamentum nuchae and spinous processes of C7 through T12. So this is another one of our muscles that has multiple or long origin points, and then it converges into one kind of area of insertion. So we have the origins that run essentially from the occiput, and then we run all the way down the spine, and then it inserts onto the lateral third of the clavicle, the acromion, and the spine of the scapula. So it's really important to remember when we look at the trapezius that again the origins are the top portion, and then it makes a T for trapezius all the way down, and that's all origins. The insertions are just the points that are out towards the shoulder. And again, that's the lateral third of the clavicle, the acromion, and the spine of the scapula. Runs all the way along the spine. The trapezius is innervated by the spinal accessory nerve and the cervical plexus. And then its motions depending on which part of the trapezius we're talking about. So the upper fibers help to extend the head and neck. And then if we only look at one side or the other, it laterally flexes the head and neck, helps with rotation, and then it elevates the scapula and upward rotates the scapula. The middle fibers are responsible for adduction or retraction of the scapulas and are a key factor in stabilizing the scapula. And then the lower fibers help to depress and upward rotate the scapula. The latissimus dorsi is another muscle that has a really long origin. Again, we have that origin that exists medially, and then the fibers project out towards the lateral sides of the body. The latissimus dorsi originates on the spinous processes of the last 6 thoracic vertebrae, so T6 through T12, the last 3 or 4, depending on the person, ribs, the thoracolumbar aponeurosis, which is this white, big, large chunk of fascia. We also call it the thoracolumbar fascia. And then the posterior, posterior portion of the iliac crest, and it covers over those SI joints. It inserts into the lesser tubercle of the humerus. So we see that insertion all the way up by the glenohumeral joint. So again, lots of origin points, big, long origin. Especially when we consider this thoracolumbar fascia as a point of origin, and then it inserts into one small tendon on that lesser tubercle of the humerus. It's innervated by the thoracodorsal nerve, and then its motions, much like the trapezius, are multiple. So we have extension of the glenohumeral joint and adduction of the glenohumeral joint, as well as medial rotation on the shoulder of the glenohumeral joint. So it's important to note that insertion onto the humerus is more towards the anterior portion, and the muscle is coming from the posterior side. So if we look at the line of pull of this muscle, as it pulled backwards, it would not only bring the humerus backwards, but it would also cause it to rotate internally towards the body, hence the medial rotation of the glenohumeral joint. We have 2 teres muscles. We have teres major and teres minor. Teres major is the muscle that has a small gap between it and our glenohumeral joint. So we have this open air space between. So this is our teres major. Our teres minor sits a little bit more laterally on the scapula, and there is no space between the teres minor and the glenohumeral joint, so it sits very flush. So our teres major originates on the inferior angle of the scapula, as well as the lower half of the lateral border of the scapula. So it sits kind of right along here, and it's hard to see because the muscle is covering it. It inserts on the lesser tubercle of the humerus. So again, we're looking at this from a posterior view because there's the spine. So on the front side, we had that greater tubercle here and the lesser tubercle that was more medially, so we can't see it. And there was the crest that comes down from the tubercle, which is where teres major will insert. It's innervated by the lower subscapular nerve, and it helps to extend, adduct, and medially or internally rotate the glenohumeral joint. Teres major works really closely with latissimus dorsi. The motions that they cause are the same, and obviously the latissimus dorsi is a much larger muscle, so we know that more mass correlates to more force. So teres major is kind of a synergist or an accessory muscle for the latissimus dorsi. Teres minor originates on the superior half of the lateral border of the scapula. So again, we can't really exactly see the origin because it's underneath. And then it inserts on the posterior side of the greater tubercle of the humerus. So again, here we're looking at a posterior view because here's the spine. So it inserts on that posterior aspect. It is innervated by the axillary nerve, and it helps to laterally rotate, adduct, extend, horizontally abduct, and stabilize the head of the humerus into the glenoid cavity. So again, it causes a lot of motion at the glenohumeral joint, and then it's also a primary stabilizer. Teres minor is a portion of the rotator cuff. So we're going to talk about the rotator cuff, the rest of those muscles on the next slide, but we also consider teres minor to be a portion of the rotator cuff. Two other muscles of the rotator cuff are the supraspinatus and the infraspinatus. Again, looking at the posterior side because here's the spine. The area above that was called our supraspinous fossa, and the area below the infraspinous fossa. So we also have the supraspinatus muscle that sits on that supraspinous fossa, and our infraspinatus muscle that sits on the infraspinous fossa. Here we can also see our teres minor, like we talked about on the previous slide. We know it's teres minor because it originates on that top half of the lateral border of the scapula, versus our teres major that would originate down from the lower half in the inferior angle. The supraspinatus originates in the supraspinous fossa of the scapula, so that whole area is considered its origin, and then it inserts on the superior portion of the greater tubercle. It's innervated by the suprascapular nerve, and it helps to abduct the shoulder, and then as a member of the rotator cuff, it's also responsible for stabilizing the humerus in the glenoid cavity. Our infraspinous fossa originates in that infraspinatus originates in that infraspinous fossa, and then it also inserts onto the greater tubercle, but like the teres minor, it inserts onto that posterior aspect. It's innervated by the suprascapular nerve, and it helps with lateral rotation or external rotation, adduction, extension, horizontal abduction of the glenohumeral joint, as well as stabilization of that humeral head in the glenoid cavity. The last muscle of the rotator cuff is our subscapularis. So again, it sits on that interior side where the scapula articulates with the ribs, and that's where it originates. So it originates on the subscapular fossa, and then it inserts onto the lesser tubercle of the humerus, again on the interior portion. So it runs from the posterior side of the rib cage across the front of the glenohumeral joint, and then inserts onto the anterior side of the humerus. It's innervated by the upper and lower subscapular nerve, and it contributes to medial or internal rotation of the glenohumeral joint and stabilization of the head in the glenoid cavity. So again, just really quickly, we have those four muscles of the rotator cuff. We have the supra and infraspinatus, teres minor, and subscapularis, and that's primarily responsible for stabilizing the head of the humerus into the glenoid cavity. It also contributes to rotation of the shoulder as well as abduction, but its primary responsibility is stabilizing that humeral head in the glenoid. So our rhomboids are another muscle that have a major and a minor. Rhomboid major is the larger muscle that sits inferiorly, and rhomboid minor is the smaller muscle that sits superiorly. Both originate on the spine and run to the medial border of the scapula. The rhomboid major originates on the spinous processes of T2 through T5 and then inserts onto the medial border of the scapula between the spine and the inferior angle. So again, we see the bottom of the spine and then down to the inferior angle, and originates again from T2 through T5. And then rhomboid minor originates on the spinous processes of C7 and T1, so we only have 2 vertebrae, and then it inserts onto the upper portion of the medial border of the scapula, essentially right along the spine of the scapula. They're innervated by the dorsal scapular, again coming from the brachial plexus like with all of our other nerves, and they're responsible for adduction or retraction of the scapula, elevation of the scapula, and downward rotation of the scapula. So downward rotation going this way. These are 2 of our muscles that are primarily responsible, along with the trapezius, for stabilization of the scapula. The levator scapulae is one of the few muscles that primarily is responsible for moving the scapula. So when we look at the rhomboids, they were responsible for moving the scapula, but they're also really responsible for stabilizing, and they also kind of work with the trapezius and can cause some motion at the glenohumeral joint. The levator scapulae really can only move the scapula. It's a smaller muscle. So it originates on the transverse processes of the 1st through 4th cervical vertebrae. So through C1 through C4 is where those are going to originate on the transverse processes. And then it inserts onto the upper medial border and superior angle of the scapula. So right along here. It's innervated by the dorsal scapular and cervical nerves, again coming from that brachial plexus, and then it's responsible for elevation of the scapula and contributes to downward rotation of the scapula, and can also help the trapezius with lateral flexion of the neck and a little bit of rotation. So because it acts on C1, which rotates on C2, it can contribute some small amounts when helped by the trapezius 2 rotation. Serratus anterior is another really unique muscle that we would kind of differentiate as a blend between a strap muscle and a multipinnate muscle because it has so many different sections to it. We could either split it up and look at it as little individual strap muscles or a multipinnate muscle. So it originates on the surfaces of the upper 8 or 9 ribs, and then it inserts onto the anterior surface of the medial border of the scapula. So this is one of the rare exceptions also where the origin is considered to be more anterior and lateral to the insertion. So typically we think of the origin as being more medially and more superior. In the case of serratus anterior, it's actually backwards. So our points of origin again are on the ribs between 8 and 9, and then our insertion is onto that anterior surface of the medial border of the scapula. So if we were able to see underneath the scapula is where that would insert into. It is innervated by the long thoracic nerve, and that's something that can cause some substantial scapular winging, and we'll talk about that in class. And this can have 2 different actions. If the origin is fixed, or where we are coming off of the ribs is fixed, can cause abduction or protraction of the scapula, depression or downward motion of the scapula, and then it can help to really hold that medial border against the rib cage again, or prevent scapular winging. And then if our scapula is fixed, it can help with inhalation and become a muscle of respiration as well. It contributes to our breathing pattern. The pectorals are another muscle group that have both a major and a minor. So our major is our larger muscle, kind of the one that sits on top, and then our pectoralis minor is a smaller muscle that sits deep to pectoralis major. So pectoralis major originates on the medial half of the clavicle, the sternum, and the cartilage of the 1st through 6th ribs. Now this is a muscle that we consider to have 2 heads as well. So we kind of split it down the middle, and then we have what we call the clavicular head and the sternal head. So the portion of pec major that originates from the clavicle, we call that clavicular head. And then where we originate from the sternum and the ribs, we call the sternal head. And those insert on the crest of the greater tubercle of the humerus, and it's fairly far down, so it's kind of halfway between the greater tubercle and the deltoid tuberosity. It is innervated by the medial and lateral pectoral nerve, and it helps to cause adduction, medial rotation of the glenohumeral joint, and then it can help to elevate the thorax in more of a forced inhalation surface, especially if the arm is fixed. And then those upper fibers specifically can help to flex the shoulder and horizontally adduct the shoulder, or the clavicular fibers. And the sternal fibers, or the lower fibers, can also help to extend the shoulder. Pectoralis minor is another one, just like we saw with serratus anterior, where the origin and the insertion appear to be a little bit backwards. So here the origin is on the 3rd, 4th, and 5th ribs, and those converge to insert on the coracoid process. So this is a good example of one of those tricipital muscles. It's innervated by the medial pectoral nerve, and its actions are to depress the scapula, abduct or retract or protract, the scapula, and then it can help to kind of tilt the scapula, lifting that inferior angle off of the posterior side of the rib cage. The subclavius is likely the smallest muscle that we deal with in the shoulder complex. It originates on the first rib and the cartilage coming from the first rib, and it sits right underneath the clavicle, hence the name subclavius, and it inserts onto the inferior lateral aspect of the clavicle, again more towards that acromial end. It's innervated by the subclavian nerve, and it helps to bring the clavicle inferiorly and anteriorly as the scapula is moving. It helps to elevate the first rib, and then it's also a stabilizing muscle for the sternoclavicular joint. The bicep is a muscle that we'll revisit again when we get to the elbow section, but we always talk about it with the shoulder as well because of its close proximity and actions at the shoulder. So we have two heads when we look at the bicep. We have our short head and we have our long head. So the long head sits more lateral to the short head. So long head, lateral, both have L's, and then the short head is medial. And they originate, the short head comes from the coracoid process, so we see it up at the top. And the long head comes from the supraglenoid tubercle of the scapula, so right up on top of the glenoid fossa. It's kind of difficult to see here. And then they insert onto the tuberosity of the radius and the aponeurosis of the biceps brachii. So as we get into the elbow, we'll talk a little bit more about this insertion complex. It's innervated by the musculocutaneous nerve, and its actions are to flex the elbow and supinate the forearm, as well as contribute to flexion of the glenohumeral joint. Here, this also really shows us nicely that bicipital groove or intertubercular groove, as well as our greater tubercle and our lesser tubercle. And again, we can see those crests on either side of that groove that we've talked about muscles previously inserting into. So the bicep tendon for the long head of the biceps runs right through that groove and over top and kind of hooks around the lesser tubercle of the humerus. The triceps we will also revisit when we get to the shoulder. This is one muscle that we can either refer to as bicipital or tricipital, depending how we're considering it. We're going to look at all three heads. So the long head on the triceps is more medial, the short head is lateral, and then our medial head is underneath that you can't really see here. So the long head, again, is going to come from the infraglenoid tubercle on the scapula, so this area right below the glenoid fossa. Our lateral head, it comes from the posterior surface on the proximal half of the humerus, and it has a fairly long origin point here. And then our medial head is on the posterior surface on the distal half of the humerus, and it essentially sits all the way underneath the rest of essentially the belly of the tricep from the long and the medial head. And then they all insert together in essentially the tricep tendon on the olecranon process of the ulna. It's innervated by the radial nerve. And it helps to extend the elbow, and then the long head also helps to extend and adduct the glenohumeral joint. So to run through identification of these muscles kind of as a group, we'll start usually with the deltoid is where we would start. So again, we want to identify the posterior, the medial, and the anterior portions. Then looking at the trapezius, again, same thing, identifying the upper, middle, and then lower fibers. Looking at the latissimus dorsi. Then we have rhomboid major and rhomboid minor. Then we locate the spine of the scapula, and we have the supraspinatus, infraspinatus, teres minor, and teres major. We have the triceps, and on the anterior side we would have the bicep. We also have on the front side of the scapula that we can't see, we would have our subscapularis, and then here we have our levator scapulae. We would also have our bicep and our pec major and minor on the anterior aspect. So please make sure you run through these muscles through the origin and insertion. work through the chart as you're going. There is a quiz that will be due on Wednesday, so make sure that you watch the video and give yourself enough time to take the quiz. There's a worksheet that goes with the muscles as per usual, and then the video that goes with the elbow will be up shortly, so you can begin on that one as well. Again, there will be a little bit of overlap on a couple of the muscles when we move into the elbow, and then again some overlap as we move into the forearm and the hand. So in class, we're primarily going to talk about the mechanics of the shoulder. We'll look at the specific articulation of the glenohumeral joint and the scapulothoracic joint, how that relates to motion of the clavicle, and essentially how those motions happen. So we'll look at the muscles that cause them and the innervation in a little bit more depth. So please try to come to class knowing the muscles and the names of the joints and the structures so we can talk about their function more than where they're located.